Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 187. A very happy new year to you from New York on this extremely cold morning. A beautiful teaching case we have for you to start the new year. I remember CTOs are generally watched by a lot of audience. They become some of the most popular archived cases too. This particular case this morning today, I think will offer you absolutely the best tricks you will need. It's going to be a straight, I think, retrograde CTO, but let me not take away the thunder from this exceptional case which has been selected for you. Let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are there. And Samin, I also know that you're going to show us some data this morning about the hospital and its volume and some of the results. Beautiful. Good morning and a very happy new year to you and the staff in the Cath lab.
Yep, and good morning to all our viewers of the CCC Live in 170 countries and 25,000 our viewers every month, and myself, Dr. Kinney, and we are two fellows today, Tushar Mishra and Santosh Vamuri. The rest of the staff, our nurses, Will, Alina, and Tech, Asif, and Naira, and imaging, of course, Kiski, if needed. Whether we need or not, we'll need to look into it. But yes, there has been a quite demand. You know, we always ask our viewers that which type of case you want to see. And I'm sure with the calcific bifurcation, we are taught everything. So therefore, there was a big demand of the retrograde. And this case happened to be the ideal case for retrograde, and which will show you why, as we made in the e-blast announcement, that there is no cap. So ambiguous cap at the Ostial LAD, ideal case for retrograde with a great collateral. With that note, again, welcome 2025, and we expect will be better than 2024. And how was 2024? And let me show you one by one. As you see that we are trying to change the logo on the top. Mount Sinai Fuster Heart Hospital. Then we also have created now SP and SEMA Loia Cardiovascular Clinical Institute. So I have made it on the one side, and we try to see, we'll be using that as a part, and of course the target audience, because it's a CME event. We are still continuing CME on the live cases, not the our archives cases yet. Rest are the same accreditation and 1.5 hours, those who attend, and at end of it, and myself, Dr. Kinney and Dr. Samir Mehta, these are all our faculty and the disclosures. And these are our supporters, which continues to increase. And the off-label use will keep it, but we'll announce what is the off-label is. So to say that how did we do last year from the institutional point of view? These are our numbers. Yeah, for last 5 years, as you can see, the continuous growth in intervention, additional 5% in a coronary and total interventions, and individual, I would call it a hat trick, in the sense that we had a growth in PCI, we had a growth in PTA, and we had growth in TAVR and TAVI, basically. So clearly, the growth from 3 to 8% in all three aspects. Of course, the valvuloplasty goes down with that expected. More importantly, which I'm proud of, is our complications. And complications basically are shown in this slide again. Again, remain all less than 1%, all taken together. And as I said very clearly, that 3543 of the 3557 patients which came to the cath lab, including with a cardiogenic shock, they were discharged alive. And that's a tremendous, I would say, the satisfaction for the great work our cath lab doing with myself and Anu having a 50+% of the interventions. Now, we see very good data at the Sinai level, but what about the state level? They keep giving us every quarterly update compared to the old with the New York State. As you can see, height of the red bar, always lower, as you can see here in majority of the categories except the perforation. Now, what we learned, the ACC NCDR has started reporting recently the kidney injury, AKI, which is the increase in creatinine of 0.3. So we do have the slight uptake in there, but otherwise we have done very well in terms of major complication, which is for the country 2.4, and we are 0.8, so 1/3. Very proud of that. And of course, atherectomy volume remains about 25%. Overall, the MCS support with the balloon pump, Impala, and ECMO makes around 5% of cases. And of course, we still have the old report of 2019. We don't have the latest report, which was supposed to come from the New York State. With a 30-day risk-adjusted mortality, we're still significantly lower. And this actually also, the structural program has grown tremendously. As you can see here, overall about 850 cases done with the tower, mitral clip, and what was added is basically tri-clip and the TTVR, complete replacement of the tricuspid valve with the Evoke. And TMVR is small number, VAV, BMV, central ablation, PFO, LAO closure. We do very few LAO closure because EP team does over 200 left atrial appendage closure at Sinai. With that note, I take you to our today's presentation. As you mentioned, case number 187, young patient who had class 3 angina with positive stress test and basically has controlled risk factors. Has been no cardiac history before, good ejection fraction, and patient has been on good medical therapy, and the cardiac cath was done last month at outside hospital, which revealed 2-vessel disease, LAD CTO, Ostial, and lesions in the circ with a normal EF and syntax score 23. So patient had a PCI, calcific lesion, so 2 stents after Rota, and then added beta blocker and clopidogrel, and then they still thought that since Ostial LAD closed, it was done outside, they felt patient should go for bypass surgery, but patient declined, which I would say that even if the Ostial LAD closure, you still give it a chance for the PCI. So this case, now, then they still did a stress test again, and patient is still positive anterior wall with fallen EF, almost 8%. So therefore, patient has been brought now for intervention of the Ostial LAD CTO via retrograde approach due to ambiguous Ostial LAD cap. In terms of appropriateness, this patient clearly makes it because of the symptoms and medical therapy. Now, Anu can tell us what we are seeing in the angiogram. Anu? Okay, look, go to the angiogram now. Yeah.
Now just mild hypokinetic apex.
No.
So this is where we are. So
Anu,
you go with the two
absolute-
guides. You see the right coronary artery, we have a AL guide, AL 0.75. So you can see the septals getting into the LAD. Important thing is where to then identify which septal. So I'm trying to see if we can still see a gap in the proximal, where the proximal or ostial LAD comes out. It could be that you see a little
That blip before that ramus.
Before the ramus, that
Yeah.
could be it.
But it
I've
looks
done
very
multiple
suspicious.
views, but you don't see.
Some people say we do the IVUS and look into it where
Yes.
the occlusion is. I mean, I don't know whether that will help us, but we can have IVUS ready in case we need it. Because
I don't open the IVUS
no?
yet.
Okay.
No, please.
All right. So tell us what your strategy now.
No, I'm going a retrograde to begin with, and if you see here, I think in the cranial picture, maybe the second or third septal.
Okay.
To get into there are a few septals, right? The first septal, the second septal. So if you see at the PDA level, to just surf around there and see which is the septal that we can use.
I mean, straight away the question has come regarding the option of IVUS, and this is coming. I had not met this person here before, Dr. Hasya Shah.
No, but I think the question basically is that what if you do the IVUS of the left main and you see the ostial occlusion, and then you try to poke, particularly you have 7 French catheter. We put a 7 French VL3 or 3.5. What guide is on the left side? EBU 3.30. 7 French EBU, so you can keep both. You can go with the fine cross or even super cross because you need an angulated catheter and IVUS and C area of the total occlusion. As I said, yes, some people will do it. We are not, again, not a master in that, but at the same time, our biggest, the
Don't use the wrong term, master.
no, but
please.
for the I was guided
Good.
CTOs.
Yeah,
No,
it's
I'm saying a
okay.
lot of people will decide based on their. We are master in the
Go.
lot of imaging,
Yes.
imaging core lab, and IH core lab is there here now. But question comes in, a lot of people will decide. But particular this case, we have a lot of demand. As you mentioned, Samir, that one of the highest our recorded case, archived case, has been a retrograde CTO. Step-by-step
Absolutely.
approach. Yeah.
And today's case has a possibility. I have lots of people joining us. Be prepared for some excellent interaction. Samin, also congratulations again on the Mount Sinai report, where volumes are decreasing around the country to have a sustained right, as you mentioned, along all the three areas. Coronary, structural, peripheral, with such an amazingly low number of complications. I have absolutely no doubt you'll be right on top when the new New York State report comes.
Just we are waiting for it, and keep the fingers crossed. We always because remember the rate is when report comes is not only the in hospital, it's a 30-day. So anytime patient was found dead or somewhere at home, it will be counted in your complication. So many of those things happen. Patient for something goes to other hospital and had the event. And actually, New York State is very clear on those. That if patient went to another hospital and the procedure was done for that vessel, which you did, let's say patient developed stent thrombosis, and they try to do a PCI, and if something happens, that is our mortality. Even if it was done, let's say, at NYU or Columbia. But if they did a different vessel, and patient died because of that, so that will be counted their complication. So they are actually quite clear cut in terms of what should be accounted for which center and so.
So, Samin, many questions shooting up. One of the people again have suggested that they felt there may have been a small stump on the LCA angiogram. We'll take a look at it later.
Yeah.
But thanks for being observant. And another question by Dr. Mahmood El Rais, could pre-PCI CT help understand the course? Excellent question.
Yeah. So, but my question is pre-PCI, yes, but in this particular case, we see very clear already that we know because angiogram has been done. So if patient, let's say, had a workup and then only have a CT, yes. But here we know it will, what CT will tell us exactly the stump. Area stump, and we know roughly stump will be little few millimeter away from the ramus. So that will be like blindly poking, and that will be the second approach here, that if we have trouble in navigating our catheter retrogradely, we'll go and do a basically poking in that area and use the IVUS at that time. We have 7 French guide catheter, so that we can have both IVUS as well as some angulated catheter to make that point. So right now, Anu, you have a Corsair, and what wire you're using?
So we need 150 Corsair. This was a regular fielder. You have fielder FC.
Now we are going to start with a regular fielder, yeah.
Anu, an opportunity today for you to tell us about all the wires which can be used here and the ones you
FC.
are using, as well as your thought process. Why exactly are you choosing what you're doing? Samin, you're exactly right. The New York State database is possibly the world's most respected. It is extremely strict, very meticulous, and to be on top of it, I think is there are all sorts of databases which are flagged for fudging some of this is the strictest, the best, and the greatest, and to top that is probably what, 8, 9, 10 years in a row.
Actually, very interesting. Now, the report started in 1995,
right?
And now we are 24 years, and I can tell you, in 24 years.
But the number of reports, it comes every 2 or 3 years, no?
Yeah, no. Actually, ideally, it should come every year, but it's a 3-year behind.
Right.
The report comes once a year. Now, since COVID, nothing has come for last 4 years. That's the reason. Otherwise, it comes 3 years behind every year. And it started in 1995. And that is where the whole thing happened with me, that in 1995 data when came, at that time in 1994, I did 572 PCI in those days and has zero mortality. And that is how I started my career. I would say then became the cath lab director, this, that, everywhere, by the state report. So state was my biggest publicity back in 1995. Yeah,
Well,
tell us,
it
keep
is.
telling us what you're using.
If you give me a chance.
Yeah, go.
Okay, can we show the slides for the wires? I'm just thinking field or
Anu and Samin, uniform appreciation from
Run
our
through.
audience for
Get me a
showing
run
this
through.
particular case.
Yes.
No, I just, not that slide. Go to the next one. Yes. Okay. So the various wires, can you make it bigger so they can? So how
Perfect.
for the, yeah, now you can see it. So I started with fielder FC. You see that? Now the thing is, if you there's a picture you can see here. So you need
No, but
150.
you have to show that also both. That's the problem.
Oh, okay, hold on. So then you can go to,
Yeah.
that you cannot see.
I know.
So somehow, see the catheter there, you can see now, right? Yes. It's going
Anu,
into another small septal there. So I
right.
pulled back. I tried the fielder FC. Now you can see it exactly where it stopped. So I have to pull back and go a little bit forward. And regular fielder and fielder FC is not making that turn. So now I'm just going to go take a run through, okay? Because now it's not a hydrophilic wire. You need a little hydrophobic tip there to make that turn and get into the septal that is seen just at the 3 o'clock position.
Such a good idea to keep the wires there. Anu, specific question for you has come. A suggestion that perhaps out of all these wires, the SUO wire is possibly the best approach. Your thoughts on that? You have
We'll
it there
try.
as a 03, SUO
Yes.
03.
Okay, now you see what happened, right? How it went through. Okay, let me see if I can get here.
I mean, either you and or Anu could answer this. This is from Dr. Haider Guru. Septal surface surfing versus contrast guided septal tracking. Which is being done more in the US and which do you think is better?
No, it depends on the operator. Okay.
So personal
It's the
preference.
same thing. Yeah. So
Operator
if you see
preference, yeah.
Yeah.
Which probably could be said for almost the entire procedure. I mean, there is so much individual experience and variability.
Some die.
Sorry, what was the question? I just had to go out for.
The Anu answered that.
Okay.
It was more to do with the preference for septal surfing versus contrast-guided septal tracking. And Dr. Kinney mentioned that, look, both work. It depends on the operator preference and expertise. But those are the wires for you, 8 of them for the collateral septal branches versus cap penetration, and all the apps keep getting modified. Anything new technique, new wire, new equipment, it's all there. So keep using it.
Okay, get us that.
Samin, so when the New York State instituted and they continue doing that, like at the moment they are following CKI, did that require a lot of adjustment for you from your own tracking and QA? And I mean, it's not a easy parameter to track for every patient. we've had some technical challenge there. For a moment, I don't see the live case. I am not sure whether our audience is seeing it, but we'll reset it as quickly as we can. In the meantime, thank you for your questions. Anu, are you able to hear me? So I think all the audience is doing is they are following me, and we'll get you back to the cath lab as soon as we can. Again, there is another question of considering bi-radial approach. We'll get that answered in a moment, but hopefully you are also using the CTO app at the moment. We will, of course, try to. Okay, whichever way you have to. Yeah, Dr. El Rice, we've noticed that no live case. Clearly some technical glitch which several of us are trying to figure out exactly what happened and how to fix it. This is the humility which strikes you after years and years of making all efforts and optimizing. These things do happen. Very grateful for all of you to have been joining us. I'd also like any of you to respond. How often do you do CTOs? Whether your strategy to do CTOs is to first try antegrade in all the cases, and whether all of you agree whether the approach for going with the dedicated retrograde was the correct one there. I would like to make it interactive as we catch back on our transmission. Once again, for those of you joining us, young patient with the two-vessel coronary artery disease, critical disease in the left circumflex, which has already been treated, and now the patient comes with the ostial occlusion of the left anterior descending, no clear stump, complete ambiguity, and a preferred direct CTO in the retrograde approach. And a 7 French strategy had been used with the VL3 and AL 0.75 guide. And once again, apologize for the breakthrough in transmission. I'm sure they would have made advancements in the case. More and more of you are sending me text messages that the live case is not there, and I'm getting text messages from our the central site which monitors all of this, that we should be having this up momentarily, and that the breakup occurred at the level in the control room where we have the equipment, and there is a dedicated technician who hopefully should solve it soon. But do let me know. Very keen to know if all of you do CTOs, and whether the antegrade approach is your preferred choice. In the meantime, this morning we had also retrograde from start. This is Dr. Mahmood El Rais. Retrograde from start in selected cases, especially ambiguous cap or ostial lesion, saves time. Exactly right. I think that is the approach which we have been suggested. But Dr. El Rais, let me know if overall antegrade is your first choice. I think that has been more or less the strategy which we have been advocating here in the number of CTOs which we have been. Okay, exactly right. This is Dr. Hasya Shah. should try antegrade unless stumpless. That's a lovely way to describe it. I think our strategy overall has been exactly that. Do indicate to me also, I'm very keen to know that what is your uh, amounts which you are doing, the percentage of cases, how often, maybe once a week or something? Do you have a dedicated person in the cath lab who does the CTO? How do you schedule? I mean, these are cases. Okay, I hear Dr. Sharma in the background. Anu, we'll restore that in a moment. Samin, I can hear you. In the meantime, numerous questions which I have been answering. Okay, we have Dr. Kinney back also, and we should have the live case back for you in a moment. Samin, I had been keeping our audience occupied, checking with them as to what their approach is, and almost all of them uniformly agree. There's a lovely statement which was put in there that, again, this is Dr. Hasya Shah, should try antegrade unless stumpless. Okay, we are back live. Anu, sorry.
And this is the stumpless.
Sure. Yeah, that's a lovely, nice way to express it. Anu, bring us up to speed.
No,
with
just
what
one second.
doing.
I think this question is coming up. Go to the fluoro, please. Yeah. Go to the fluoro. Fluoro is not going. Yeah, good.
Slides,
so let me go back to the beginning.
Cyan black?
Cyan bars? Next to, it's next to another one. It's
No. In your,
next to,
yeah. Go
cyan
back.
black and silver.
Okay. Look at that now. One and the second. Let me show it here.
No, but in that thing,
Well, it's not one
antegrade, we didn't mention that?
And show it here.
Yeah, go back. Yeah, there.
Third.
Not that.
I think this is the most important. See what is this? The ramus, and there is no
Not
stump.
this one.
So by
One that you
definition
showed
becomes
earlier.
ambiguous cap.
Yeah.
It may give you about 4 millimeter proximally, maybe a little 0.001 millimeter, but nothing. So there is no cap. So stumpless, as mentioned, this is where we are. And now Arno is going to tell us where we are now and what we have done so far. So when we become, apparently there was some issue with the rebooting. Okay, and that's where you are.
Yeah, so if you see here, PDA, remember tortuous PDA. So the wire kept going.
Yeah.
You see that wire kept going to the, go minus. What are you doing? Okay. This is where I think we showed that we
I
needed
think
to
this
change
is
the
where-
wire.
Yeah, we lost you after this.
Let me just keep going. So this is where we are. Up to here we were with the fielder. Then we changed with fielder FC. So we pulled back. So actually we have the 150 Corsair. So we pulled it back so that the fielder FC can make the turn and get into the septal. But it was not doing that. So that is the time to make that turn. So all the time what we were using was polymer coated hydrophilic wires. So now we wanted a non-polymer coated tip. Okay, so the easiest one that we could find was a run through. So with the help of the run through, we were able to make the turn. Now this is again the same thing. I think what happened with the run through is that we made okay, this is the one we made. So what happened is with the help of the run through, we made the turn. But more important is there were suggestions, right? Various wires, which are the surfing. So going back to the point of surfing versus the selective injection. I don't like selective injection because one, often you don't see it well or you could see it well. Two, when you're injecting, there's a risk of little hematoma formation. So, injection through the microcatheter into the septal, I don't prefer it. So this is where we use a run through. You see that? As we were trying to do that, it made the U-turn. It made the U-turn and we went into the PDA body proper. This is the run through.
So at least provided that strength to get your Corsair further.
Yes. So you got the U loop. When you get the U loop, you take the advantage. And try not to, even if it goes into the septal, try not to go into the septal with the U loop. There's a risk of little perforation or hematoma formation with the septal. So once we did that, now you go back to the other wire. So we had already tried the regular fielder, and then we go to fielder FC. Andrew, can you go back to the slide of the wires?
Yes.
So let's go one by one. Why did we choose each wire? Yeah, so fielder FC. So this is all the wires that are available, and more actually. So you remember XTR, cyan black, SU03. So the question you will ask me is, why did you try cyan black? Why did you go for fielder XTR? So again, I just wanted a polymer jacketed hydrophilic wire. So we went to cyan black. So can you just show the individual wires? Do you have the picture of the individual wires, cyan black versus SU03 and fielder XTR? Yeah, let's go there. Because right now you are in the septal, and then you want to go through the septal. Atraumatic, okay, atraumatic traversing the septal should happen. So if you see the fielder FC, if you see the tip load 0.8 and look at fielder XTR 0.6, one of the big difference of XTR is it is tapered. It goes to 0.001, and if you see there's a hydrophilic coating also at the tip there. So we liked fielder, that's fielder FC, fielder XTR. Now go to cyan black. Yeah, tip load is very small. So these wires have to have a very little tip load so they can traverse through the septal very easily. So you have SU03. So what was mentioned to us was a SU03. So whatever you have and whatever you're comfortable with, you can use it. So XTR, so most people will tell you when you're doing, use XTR only because it's tapered. The rest all are not tapered. The tip remains the same. So we took the cyan.
Cyan black.
Yeah, and then that's the one, right? Yeah.
Yeah.
Anu, excellent demonstration of the wires, and I'm amazed at Andrew how he had all these slides immediately available.
No, we had pre-planned all this.
Very
He
good.
came very early. We knew that this is the step, this is the step. I told you one day he will be doing CTOs maybe.
Virtual.
He already knows.
Virtual
He already knows how to do bifurcation.
With the AI.
Yeah, he
Not
already
hands-on
knows.
AI.
Yeah, what I meant is he already knows how to do bifurcation. Why? What happened?
Samin, many more questions coming in from our
No,
robust
but 1
audience
second.
here.
Yeah, but Anu will complete it now.
We didn't
Tell
save
us
it?
what happened.
No,
Yeah,
then yeah, we were able to traverse the septal when things were going, and now we have this one. Once we went through that wire, you know, so what is a movement? Just a simple corkscrew, you know, just keep rotating and advancing, rotate, advance, it will go. So this is atraumatic traversing the septal, okay? Because you cannot have any kind of hematoma or perforation of the septal. Whatever, there is a risk of a fusion formation if that happens. So this is where we are now. Okay, so we pull back, and now we want to change the wire.
Just fantastic skills. Not only am I appreciating, there is a entire audience virtually see them clapping here. Just a fantastic job. And Samin, I'm glad you stopped me there. I had not observed the tremendous progress. All of it, some of it which we could not show you on live, at least now you know exactly the thinking and the steps.
And now the real thing starts. Now we have to penetrate the retrograde cap.
Right.
Which usually should be simpler compared to the antegrade cap. But in this case, there was no antegrade cap anyway. So now which wire you have? Tell them.
Now I have Miracle 3, not 6. Normally I like this. So I have to pull this back. You have to be careful that thing will not.
Or why not? Let's say Miracle versus Gaia this time.
Yeah,
I'm sure a lot of people will go with the Gaia.
Okay, you can go with Gaia. The reason is I can make an extra curve. You see, it keeps going to the septal. I have to get into the LAD. And for that extra curve, I took the Miracle. If somebody wants Gaia, yes, they can use Gaia.
So, I mean, there are a couple of questions which I think will only add to the caliber of this beautiful case. One of the questions asked is, I'm not understanding the complete intent.
Hold on. Move your.
What about a safety wire
Can
in
you
the
show
left
the movement
circumflex?
of my wire
Yes,
fingers?
we see it. We see it very nicely, Anu.
Now tell us safety wire in the circumflex for what purpose?
Yeah, I could not understand, which is why I said I'm not sure the thinking there. Another question relates to fielder XTA.
Yeah, that's for antegrade.
Antegrade.
That's why A is antegrade, R is retrograde.
Yeah. It's about
Can we show those slides, Andrew?
Again?
All
quickly?
over again, yeah. Yeah, let's do that again.
XTA and R. We can show. But the question is, yeah, so, you know, a lot of people put a wire into the circumflex to stabilize the guide. But we are not there yet. You're right. If there is a trouble in stabilizing the guide, you'll put a wire in the circumflex to stabilize it. But we are not there yet. And that is more needed in the radial rather than femoral approach. We are the femoral. So this is the XTR. You can see there, stainless steel, compatible and core to tip with the hydrophilic coating over the polymer jacket. So what about the
change
A?
to
Call it
Gaia.
A.
That one we don't have ready.
Oh, we don't have that.
He can make it.
Yeah, we can make, but we don't use that, so we don't have, but we can make that. No, Gaia 2 or Gaia 3 now? I think you need a Gaia 3. No, are you in the same view? 34.4? Okay, yeah.
Samin, I got distracted with the numerous questions on the wires. I missed a question which came earlier from Dr. Neo. Would you have considered a biradial approach in this case?
Beautiful. I would say that many people who are radial fanatic will do the biradial, but not in Mount Sinai Cath Lab. But yes, nothing to do, nothing wrong, but I can tell you when the time will come to exteriorize the wire, and so will be very, very difficult with a biradial approach.
Also huge amount of radiation, no?
Yep.
I already told my people I'll be glowing when I come out today. So
Right.
yeah, so I think the radiation is a lot with
If
the
you
radial.
are
What is that
glowing
number?
at,
3.
if you are glowing at the end of the case with success, nothing like it.
That is true.
Beautiful, beautiful case, Anu. Great
This order.
demonstration of so many complex wire, very deft handling, and hopefully you will get through this last hurdle. I mean, this is not the last, many more, but just a fantastic teaching case to begin the year.
Yep.
Samin, you had probably stepped off the recording at that time. I had mentioned that did you need a lot of recalibration of your entire QA process that now you've got a parameter like a CKA which is being monitored?
know.
It's not
Yeah,
easy
yeah.
to do.
Yeah, very difficult, believe me. We actually, and we're trying to look into and it's a definitions and how you can check it is totally different also. And basically, AKI is defined. Those who are interested now, you know, in the past, we used to have door to balloon time has been taken out as a quality
Antegrade.
matrix. Because they know that everybody is on door to balloon time over 90% number. That's no longer an issue.
You guys keep talking. We crossed
Yeah, good. Show it.
the car. That's what's the point.
Anu,
Okay.
so what all did you do different there?
I think everybody, instead of asking various questions, you should just concentrate on the case.
Yeah,
as
they're
it's going on.
concentrating, yeah.
I can, Anu, guarantee you people are watching you absolutely closely.
Yeah.
But tell us what did you do slightly different there which made you cross there?
I changed the wire to Gaia. So we are in the,
But where are you now?
yeah, I hope we are in the left
in the
main
left main.
anyway.
Right.
So
Not
now
in the
to
left
confirm it, we'll go to the caudal.
Caudal
Can
view.
you move this a little bit?
No, the AP
So the
caudal
mo-
will be okay.
The most challenging part is to get into the guide. Okay, you're going to give me? Yes, left picture. Who knows? Is that the... No? I think that's it.
Do you want to just go to AP caudal?
AP caudal?
No, I'm saying.
I would now get that, you are the fielder wire, right? Didn't we have the fielder wire?
Fielder, whisper, which you
No,
do
no,
now.
no. Actually, get me the, okay, let's try it. Fielder or run through? You have the run through, run through. Yeah, give me the run through. Yeah, yeah.
So basically, now your wire has gone through the Ostial LED and has come out.
Yeah, that's what it looks that way. So now I have to get into the, we have to confirm that. Wait. And then we have to get into the
Left main.
left main.
Left main. Yeah.
I'm magnifying this view.
Okay, take it
Was
out.
Buddha there
Take it
today
out.
or no?
I think he was on call.
Oh. That lady?
Samin, would you feel that just as a principle for helping the patient as much as one can, that sites which are really not doing too many of these CTOs, that at least some of these upfront retrograde should be referred to a site which has more expertise?
Yeah, so actually, in the guidelines, there are the same that patients with a high complex CTO, which is basically defined as a CTO score of 3 and above, J-CTO, and this case has a CTO of 4. So those should be referred to the center, which are expert like ourselves. So here, same thing. It was done outside. They wanted to send patient for robotic lima, one vessel bypass, because they felt it will not be able to recanalize, and came to Anu, and Anu looked at it and said, let's try it. And that's where this patient is. But yes, these are challenging and tough cases, no matter where they are, but the clearly should be reserved to the center, which are expertise in this kind. Yeah.
I mean, to me, as soon as I saw this case when it was
Get me the Confianza 9.
sent to us, was what an exceptional teaching case, and it really requires a lot of confidence and courage to be doing this online.
Right, absolutely. But we actually had a request for a while now
Right.
on these retrograde cases. So therefore we felt that this will be the most appropriate one. You are right. It's a challenge. It's a risky in the sense that if you are failure, but I think it's appropriate. We all are. We learn every day. We learn, and the whole purpose of teaching. So this will be bad. So now going with a stiffer wire, Confianza, to make a turn into the left main, right, Anu?
No, I think we are a subintimal.
Okay,
So
which
I have
is
to
okay.
pull back a little bit and
Okay.
then get intimal and pierce the
But do you want to go to epicranial first or no? You are happy? No, I think
No,
I
no,
would
no,
say
you know what?
go epicranial first to see where you are. Or areocranial means
don't
in
know.
relation to where your tip of corsair is. You may not see anything.
Yeah, that's
The
why I
caudal.
said.
Then you want to go to caudal? Yeah, caudal. Because we have to
Epicaudal?
see. You have a very small gap left now. Little areocaudal means, yeah. See this now. You die. So you have directed already into the LED side.
No,
I mean
no,
left
it's
main
not. Yeah,
search side.
Okay, so you can want take us in a wait.
Yeah. Retrograde.
This one, antegrade.
I mean, another suggestion, would you consider the Mongo here?
Not at this time. No, we have to pierce the cap.
We actually had the Mongo ready earlier, and here you have to clear the cap now. Pierce the cap. Take a picture now. Looks like we have done it now. No.
And more suggestions that a Gaia 2 with
Yeah.
the small curve.
No, we
No,
did
that's
actually.
what we did already.
We went to, yeah, that's what we did already. So that didn't help us.
No.
Anu, just to make you feel, which you should feel very happy, people following every movement you make. They are watching you very, very closely and learning.
You want to magnify more? Or you're okay. It looks like we made some progress. Take a picture now.
The thing is,
Retrograde, let's see. I mean, look at the LED overlapping the rims. Anybody predicted that you integrate with the IVUS on the left main would have told us answer that was absolutely no. What is happening, patient?
Okay, now get me that run through.
Okay, get the run through now.
No. Hold on. We had no.
Yeah, new.
Okay.
So this is your Confianza 9, correct?
Yes.
Yeah.
Actually, wish.
So that is, oh yeah, good. No. So no, this could be. Could be.
Okay.
Yeah.
Now die.
Yeah.
Document again that we are in the left main lumen. Could be.
Yeah.
The way it went, right?
So just to say,
We are hearing the noise from the control room. Can you hear?
no, where is the
Just me?
Where is the noise?
I have
you
a
can't
very,
hear?
very perfect transmission, Anu.
No.
Okay. So maybe I tell him to. I can hear it.
Yeah, we'll correct it. Anu, more questions coming. A knuckling of the wire through this cap.
No, but I think we got into the left main already. Yeah. We are in the left main now. And now we have to get this into the guide catheter, then exteriorize the wire. The Confianza 9 or 12?
9.
9. The 2PS, the cap, retrograde cap, they needed a Confianza 9. But yes, we did try the Gaia 2 and 3. I mean, Gaia 3 actually. And then second, stiffer wire, I mean, we got.
So once again, Samin, the suggestion has come
Miracle 3.
specifically.
Yep, Miracle 3, the Gaia, Miracle 3, Gaia 3, and Confianza 9.
From Dr. Mahmood Al-Rais, wiring circumflex at this stage.
No. Epicranial? No.
Every possible challenge.
Ask Mohammed Ayaz that what is the logic. I'm sure he's asking that question consistently. So let's find out that what is the logic of wiring the circumflex. From his point of view, as long as the guide is a good support.
I'm sure he has heard it.
Yeah. Yeah. So he can type it. So we all need to learn what this is. And so.
So, I mean, all of us are busy operators in the cath lab.
Yeah.
I think a point which we also need to emphasize each time we are showing a CTO is that, dedicate complete attention and time to such cases. These are not cases you're going to ram through, and total commitment and skills, and a very large portfolio of the guide wires.
Not only that, time. So what we do not schedule usually our CTO scheduled CTOs are, because CTO is rarely ad hoc. CTOs are usually scheduled, and we do it on Tuesday up to 3 cases. Sometimes more, but basically our goal is every Tuesday we do 3 CTOs, and if we take overall our 3,800 intervention, the CTO is about.
Show me some die to make sure we're in the left main.
Interventions are CTOs.
Okay.
That's one. Second, the retrograde of the. Just 1 second. They're changing my mic. Yeah.
Should we change?
So of
now.
Yeah. So of the 300 CTOs we do, retrograde will be 2 or 3. But we learned that if you can do antegrade better, it's always good. Now that's where we are now, and I'm going to tell us what is the
Get
next
us
step.
that VL35 guide,
6 French or 7 French?
whatever they have. We had earlier. So because this is facing up,
Yeah.
Right.
I need a coaxial guide. Yeah. Hold on.
Okay,
Seven what?
so here is some
3-5.
further thoughts about the left circumflex and the thinking.
Yeah.
Although we had asked Dr. El-Rais, but Dr. Hasya Shah provides, I think wire in the left circumflex is important at this point. If you mess up the left main, perhaps wire in the circumflex can save your day. Keep left circumflex open. Good thinking. Good
Yeah, I know,
thinking,
but
not necessarily,
not necessary. Yeah.
you
Yeah,
know,
but the
it's
same thing,
probably
you know.
overkill
Oh,
here.
overkill. Yeah. No, but if we
Careful,
will see,
careful,
the
right?
key is that we have the wires, we have everything there. If we feel that something going in that direction, that will be the first thing we'll do. But should we do it preemptive, prophylactic? Answer that is no. So
I
remember, we
think
need to do minimum but necessary things. Yes.
so. So, Samin, I'll add an exact word which I think explains your thought process and what Dr. Kinney has been showing in each case. Stepwise, it has to be a stepwise approach. Don't need to circumvent that and. But of course something which we've had at the back of our mind. Another very important question: how frequently are you checking the ACT and what is the target you have in mind?
Yeah. So this patient actually happened to be an angiomax. Usually we do CTOs on heparin. But this case was started on angiomax, which we are doing quite happily. But yes, if you're using heparin, then you do every 30 minutes. We check the ACT keeping between 250 to 275. As soon as you recanalize, then you give extra bolus to bring it to 300. And also we try not to give a strong depth. So this patient has been on clopidogrel, PRU was checked, is 245. So patient is kind of non-responder. Anything more than 228 or 230 is non-responder. So once we're successful, we are going to change to a stronger depth in this particular case. Young patient, we are going such a complex intervention. So this patient, then we are going to change it to, usually the Procedural is our favorite. A lot of people use a ticagrelor, but that I'll leave it to Anu. So what you do is, in this case, you give a 30 milligram after you recanalize, you give 30 milligram loading dose. You don't give 60, 30, and based on the weight, you give 5 or 10 milligram. Okay.
Absolutely excellent suggestions. The way to proceed with these cases safely to keep the ACT in the
circ. No, you know it is circ, right?
Yeah, no.
Okay.
Yeah.
We are in the left main.
No,
Now
no,
the
take a picture, take a picture, but it's good for everybody. Yeah.
Okay, that's what I said. I thought.
Yeah.
Okay,
So
good.
see, so we have come there, right there. Here is the circ. So therefore, this part is correct. So far nice. Now question is, you can use angulated catheter 1 or maybe
No,
just.
you cannot. How angulated catheter?
It will be
From
very
what?
tough. Huh?
You cannot.
Yeah.
You can't move the angulated catheter all the way now.
Yeah.
Plus, they don't come 150, right?
Yeah. Good.
Anu, which was the guide you had changed to?
VL. Now VL 3.5 compared to EVU because EVU was pointing up.
See, this one is left main there.
This always happens. You have come, maybe you're part of in the wall of the left main there. So use maybe our fancy whisper wire.
If this
But so close. Look at that.
See, this was that original.
So it's
What
come
for
to
what?
that.
This
come
guy
to
also
that,
is like wire in the circumflex. How is wire in the circumflex going to help you?
knuckling.
Listening to him.
Guys, yeah.
I would use the whisper.
It has also been suggested by another
Yeah.
operator, but every conceivable challenge, so near and yet so far.
Earlier, you were able to get a wire into the aorta, out of right.
Now I think I'm again.
Anu, are you too far down with the support? Maybe that needs to be.
No, they
brought
did
back.
all types. Yeah. Get a whisper.
No, I think I'm subintimal. Because when we pulled back.
Yeah.
See that? It's not going in the circle now.
Now, only question remain, what is the length of the twin pass? Or twin pass may not go, right? Is that hard? The other one is the you need a 2-hole catheter. So So you put a twin pass there and the side branch, you trying to, you know that then you are in the lumen.
Unless you want to try antegrade.
But where? You see the antegrade is over lying the ramus. You want to see the antegrade injection? Let's see a little better now. Let's see minus here.
Yeah. You don't
So
see
it is
where
coming off. It looks like it's coming off that ramus. See, so lot of people who thought there was a nib into the left main, no. The origin is coming from the ramus, or maybe then that's a proximal LAD by definition.
Very.
Okay,
Maybe, maybe not.
You have the miracle, right? 3, 6. Yeah, give it to me.
3 or 6 you want?
3. This part is subintimal. So when I pull back, so I have to come here and make that turn.
Several operators are also
Give me a new one, miracle 6.
wondering if we are subintimal.
No,
Yeah,
it
no,
is.
we know that.
Yeah. No, definitely we are subintimal there.
No, subintimal means the cap to left main, few millimeter is subintimal.
Yes.
That's why when I pull back, I get subintimal.
So here is more considerations. Antegrade wire to left circumflex and pull back IVUS.
Okay. What will that tell us?
Antegrade wire into the ramus. I mean
No, into the circumflex and do the IVUS. Okay, then what will happen?
That won't say anything. So
What will
it's
that
only
say?
thing you have to go into that ramus where it is entering. Ready?
Hey.
No.
Okay. Yeah. I thought you're pulling the. Okay, good. Now, what's the thought process there?
Run through.
I would be speculating on somebody else's thoughts, so hopefully.
No, because we were able to get into the circumflex. So goal is now little bit of that apical LAD, we don't have it, and that is where it is going into the different vessels. So that's where we are. Now we are going to pull back, going with a stiffer wire. I can tell you, still you think about using the twin pass may not be the bad idea.
It may not go through the. Remember, these are coated microcatheters.
So the further extension to a previous comment is that the IVUS may allow you to see the possible LAD ostium.
Yeah, we're trying to see how to get the wire into the guide.
And another thought which has been expressed is that leave the retrograde wire in the left circumflex
Right.
and then snare it.
Actually, the other thing I was thinking about that point, that if we leave, but question is, will it create some ostial LAD bed dissection? Because, I was thinking that your wire is into the circ anyway. Or I would still say before that, I would try with the exchange length wire, let's say run through or so, and then put a twin pass, which is 135 centimeter. I will make it 135 centimeter, maybe okay. And then make through the side hole, go into the left main. So that's what the first thing I would do before I will snare the wire of the left main and from the circumflex.
Get that confianza back, confianza 12.
12 or 6? No, okay, wait 1 second. Now
No.
we cross again. Now with the guide, we need to get into the guide.
ostium.
That's the only thing.
Get the confianza you have, right? The one that we made.
Samin, another thought,
9 or 12.
Dr. Neo, any consideration for a guide extension catheter?
But antegrade or retrograde, no. But antegrade at this time
Not
will not
needed.
help. Yeah, will
Right.
not help at this time. Oh, you mean that go a little further to get your wire back into the guide? But it's there at the ostium. I mean, we are quite there.
Oh, no.
Okay, this is
Yeah.
a much more specific, more elaborate, and more thoughtful suggestion. Remove the microcatheter wire, pull back in proximal, and small injection via microcatheter if you are in the right direction to the LAD ostium. Very good. Good thinking. Good thinking. We may need to reach there, but probably at this stage, probably other options available.
Yeah.
But all
Great suggestions. Great
all
suggestions.
excellent. You know, just
Retrograde, antegrade.
long case, committed, dedicated operators watching
Ready?
carefully, sharing their thoughts, keeping it
Retrograde
truly
first.
interactive.
And very intelligent audience.
Very
go.
intelligent.
Okay, now
Just
antegrade.
such a, I mean, I repeat my thoughts
Ow!
here. You see everything there now, no?
Yeah.
Antegrade, we see something.
Yeah, definitely you see something. There you go. There's a large, now you see the cap and the
Just
flush of
antegrade,
the
okay?
flush of the LED has increased. Very
Show
very
some dye
promising.
before I go.
Take a picture. Take a picture.
I
Now
don't see
it'll
it well.
confirm where the origin is.
I think it's too much. You have to do less LAO.
No.
It's
Here.
overlap with that wire.
No. Which wire? No. But this is better, so you see the ostium. Okay? Go. Okay. Let's
Now you see the
configure it now.
dissected one.
Now the observation is there a left
Go
main
integrate.
hematoma?
No, it's not hematoma. It's just a little.
No, now go integrate with the whisper wire.
Okay, now get us.
No, this is a very good now.
No, fielder
You have the
first.
no whisper. This is the good whisper case. This ideal whisper case. You have the whisper
I'm
or
not
what?
the whisper wire
Yeah,
person.
we have whisper. You want to go over the wire system or just direct? We can go direct here. Get a 2O balloon. Keep playing the picture. The where this is coming from. Look at that. Wow. Who could have thought that?
Yeah, no. In between, you had made an observation that it virtually comes off the ramus.
Yep.
It's a trifurcating left main.
You want to go less mag or you're okay? No, I'm asking. Okay.
Don't keep changing the.
The view.
Oh no, hold on. I said fluoro. Fluoro say what?
No, we're not showing fluoros here.
No. Means fluoro is it 7.5? Why you go negative and then
You mean the fluoro rate?
yeah.
What do you need now? This is the balloon.
Never do negative. No, I think we need a run through SS here.
Run through.
Thing is,
Get that run through back. No, 1 second.
now some die. Where are we? In the get the run through. Yeah, this is not allowing me to take
So
the.
you need some body.
Yeah.
Usually whisper should work, but it did not.
How many times I tell you 3 loops? I mean, like.
Now question to me is, do you want to go with the another microcatheter now? So in case you need to change the wire a few times.
Look at this, all destroyed wire.
Okay, give us a new
Destroyed. Look at it.
new run through.
Get us a fine cross. You have, right?
Go with the fine cross. Yeah. So see this now. Let's study while we are changing the fine cross. This is where we are. Okay, let's go with the fine cross in.
The other question is retrograde. Oh no, it's not.
No.
retrograde.
Here,
Yeah,
1 second. Here. Okay.
Yes, cannot.
Good.
Yeah, Miracle 6, right? Did I use it?
Now you can use Miracle 6. We never used before.
No, I think that we opened it, right?
No, Miracle 3. We didn't open Miracle 6, right? Okay. So now we are going antegrade. We saw some channel. And let's see if we can navigate through the dissected proximal ostial LAD. Good. I want to magnify it one less.
Okay.
Yeah. Bigger magnification, you can see better.
Now, some dye.
Mm-hmm. Now you want to see where you are there?
There's the run. I mean,
Both wire had to kiss. All there's the black portion of the wire only. Otherwise the tip should be let's
maybe only Miracle 6 may make that. We were in the Ramus, right?
yep.
Now dye.
Take a picture now. Let's take an antegrade cine. So we can evaluate what is going on there.
It's a slightly different view than before.
Yeah, little different view. But you can bring your fine cross there and then,
I think I'm.
but had to go inside first.
I am there. See.
Yeah, you have to go through it. Yeah, bring your fine cross there.
No, this is in the Ramus.
No, but that's
Very close. I think.
no, but I thought it is through the ramus. Let's study again. I thought the LED is coming through the ramus. Let's see this picture again.
No,
If I ask you all the questions now, you would be absolutely amazed at the range of people's observations and thinking. Several continue insisting on protecting the circumflex. There are thoughts about using Sion black.
No, we have the CN block. We can put into the circumflex when the time will come. But let's go through this first. Yeah.
A wire de-escalation, knuckling of fielder CT versus red. So that's what I'm saying. It's all over. Everybody is. All I can tell you is everybody's trying to think it intelligently and help you and keep it extremely increase the level of teaching.
Yes.
Very good. I want to take this opportunity to thank the audience more and more. As years have passed, we have benefited from our wonderful audiences, kept it more interactive. That always increases your level of learning.
Okay, now.
What do you need? Retrograde?
Just trying to see.
Antegrade.
And of course, a very useful suggestion of dual injection.
Yeah.
You want to use a wire here now?
So, Samin, you think the penetration has occurred that all these equipments, all these different wires are available to most international sites because they most of the people are extremely familiar with all of them.
Absolutely, there are.
And you had also
you
had also in your, I think, conversation either with Anu or with Asif, you had mentioned that some catheter or something has been back ordered, and I can relate to you a conversation I had with somebody in the industry, which said that, look, all this back ordering is happening a lot because the attention and the focus of several of the companies has moved away from PCI, which is just a standard. It just keeps the food on the table, but the real earnings and the money is in the structural. He says so. Nobody is really developing a lot of PCI hardware or even having a compulsive having them available and on your shelves. So I can. It's a very strange and a sad reflection of the economics how it works, but.
No, that is true. Also, just to give the example, the stents are now $300, $400
Right.
compared to your the
Probably even
tower
less,
valve is
probably even
32,000.
less. Yeah, probably even less.
And the balloons are 85, 65 bucks.
So look at the beauty of the observation of the people. This is again Dr. Hasya Shah. Do you think the patient has chest pain? He keeps getting his hand on fluoro. What a beautiful observation.
Show the hemodynamics there also. So, so the patient definitely is getting what? Restless or what?
Yeah, restless.
Just restless. And hemodynamics should show in the bottom. There are no EKG changes, but it just basically we know this patient they stay long. They're very restless. You want to go to cranial again? Or
What happened? What happened? Keep talking.
Wire went into the. Now you
Right.
see this now. The retrograde wire has gone into the guide catheter. Now it's simpler to exteriorize. Okay, go to the next step now.
Just exceptional persistence.
And which wire is that which went into the guide catheter?
Miracle 6.
Miracle 6 now. Retrograde
were-
Miracle 6.
You
As
were,
we said.
Anu, you had been talking about Miracle 30 minutes before.
Yeah.
That
No,
we
no,
were-
we had it
3.
ready. To
Right.
get into the guide, I wanted Miracle 6. Anyway, so now we have to go here and anchor, get the balloon, right? The thing.
All right, so
Can
it's
stabilize
all,
him?
Anu, all the emojis clapping for you. I have many of them here, and I want to, Samir, mention something else
Take
which
this out. No,
which
what
I
is
have
this?
observed over several
I have
years.
to trap. What is
Yeah.
this?
But I
2.5.
think that is also in addition to Dr. Kinney's excellent skills here. I think the supreme confidence that
Flush
look,
and keep it.
I think I can do it. And she had actually mentioned this to me ahead of the case. I said, look, this is a tough one, and she was very, very confident. And I think that not only is that such an amazing attribute to have, but so comforting it would be to the patient to feel that, look, it's a difficult case, but I am in the absolutely the best hands. Anu, everybody, they've actually used the same word. Great job, excellent, great job.
Beautiful, beautiful.
Okay.
Thank you.
It's a lot of beautiful, excellent. I can tell you, Samin, the level of the operators who are participating in the webcast today is top notch. Top
Superb.
notch.
Okay, go.
Or,
So now we are doing, keep
We are,
telling me.
we are anchoring the wire. okay?
Anchoring the wire
And then I will advance the micro catheter into the guide, which is
Okay.
on the left side. So you will not see any pressure on the left, which is the blue. Go 16, 18. Yeah, good. Right. You need to anchor.
we can remove the hemodynamics now. So
No,
that
no,
we
no. You
can-
need hemodynamics.
You
No,
want to watch
remember?
it. Okay.
Yeah, because
Okay.
because other side is closed. So
Got
that
it,
is what. So basically, you are fully obstructed now. Retrograde catheter is going back into the guide catheter, exteriorizing.
Another physician has joined us, Dr. Magid. Very important to have IVUS demonstration of the level of entry, re-entry. All good thoughts. Maybe not needed at the moment,
Now what
but
is the, we don't have RG. Okay, now the various externalizing wire. Andrew, can you show that slide again? Which one are we going to use?
also want
We
to,
don't have-
Samin, I don't know if you
Which wire are we
recognize
using?
this name. I can guarantee you it's somebody from Turkey, Dr. Erdogan Yasser, and the reason I could confidently say Turkey is because of the name of their president, President
Yeah.
Erdogan. Same pronunciation.
Yes.
Welcome to you. And of course, Anu, a whole
We are
chorus
using the
here.
Viper wire, right?
Right, chorus here,
So-
RG300. That's where we
Can we
are
put
headed.
open that slide?
There, right there, we have
Yeah.
it.
Yeah, larger.
No.
Take out everything else so we can show. No. Give me that peripheral.
So, Samin, somebody
those
picked up
wires.
exactly on our hemodynamics, some pressure changes. Anything unusual you noticed?
No, but
No.
that time, because remember when we balloon inflated, so therefore antegrade has no pressure. So that's where it was. So which is expected, that means you have a nice anchoring, and that is how the corsair has been advanced into the our left system, left catheter, and now we are here with Viper wire advance. So there are many of them which can be used, externalization.
But
they-
ideally should be the RG3. You see that?
RG3, yeah.
RG350, RG3. See the reason why it's called 350. We have highlighted why you can remember 350 and RG3. Different company makes it,
That's,
but
they had-
one is by Asahi, one is by Teleflex. So
Right.
keep them
I
with
think
you.
the one it is Dr. Hasya Shah who had mentioned RG300.
Three.
I think he's alluding
Yeah,
to
three.
three.
Yeah. It's a 3, and it's a 330 centimeter length.
330.
30.
So actually, when we used it once upon a time, the last hour we used
Yeah.
RG.
RG3. We used last time RG3.
Samin, here is the amazing part. I've never ever noticed it. I've got at least another 6 or 7 different people joining us in the last 5 minutes. I have never met them before. There is somebody, Will's boy, Dr. Erdogan, Dr. Magid, Dr.
Magid, yes.
Al-Manfi. This is fantastic. All of them are complimenting on the superb case and your skills. All of them, uniformly.
Beautiful. And now we are going with the
Which
now
is-
Viper.
which is what
Viper
our-
wire advance.
Samin, which is what our observation was at the beginning of the case.
Yeah.
We are going to have both a robust live and archived audience here.
Yes. Okay. Low mag. Yeah. See the wire coming down already, down to the pike, right there.
And the hemodynamics there.
Yeah. And the wire will come out with the
Hey,
needle.
don't move. I don't need it. I'm just doing it for them. I don't need it. Okay, get me the introducer. Okay. So when it comes closer, can we just focus on my hands here? How to
The top.
get it
No,
out?
they have it. They have it.
Oh, no, more. Take out the hemodynamics.
Okay, now take the hemodynamics
We
out.
need to see the hemodynamics.
Okay.
You can see the wire coming out.
Yes, we do.
Are they
Very-
focusing?
No.
Yes.
Guys, no, but they have to show other one. Show
on
both
the
of them.
other-
Yeah.
on the
yeah.
left. Yeah, here we go. No,
no.
Yeah, it's
Philip,
coming
Philip,
out.
go
Coming
back
out.
to
Can
where
you see it?
Philip, go back to the orange one.
Yeah,
to the
yeah,
orange
good.
one.
Yep.
Move your screen a little more to
Yep.
where Dr. Kinney's hand is.
It's
That's
coming out. You see it?
Okay,
Yeah.
here we go. Excellent. And magnify it. Here you go, Dr. Sharma. There you go. The
Yep.
exteriorized wire.
Right.
Okay. Yeah. So now what you do is
RG3.
yeah, very simple. You take your wire introducer. Ay. And then
Question is, can you go through the Y connector? Yeah.
Yeah.
Just go through the Y connector.
And then put it so it comes out easily.
Okay, and we have secured everything now.
Yep.
Okay, let flush, flush, flush.
Excellent. Anu, such a important step. You know, it's so easy to introduce air there.
Yeah, okay.
Very
Good.
good.
So now take this out.
No, this is
We can keep advancing here. 1 second. Let me go to the top again. I'll keep advancing.
Anu, here's a question. Very important. Do you push or pull RG3 or both?
No, I am just
Yeah.
advancing. You see
advanced.
that?
Yeah.
I'm doing advancing. You see that? Very important. So this is the time where you can have push-pull can cause issues with the left main. This one there is one you have to really pay attention. So either of the guide doesn't get sucked.
I think that's why to put in that Y connector there and to show it and to eliminate the air was
We got a 2.5
best.
balloon here.
Yes, yes.
We can
Very,
cut the
very
tip.
nice.
We
I
have
just
it.
noticed it, you know, the
Yeah, we
two
have it.
colored guiding catheters,
Yeah.
the
Yes,
green
yes.
and
That's
the
why
orange.
we made it
6
like
and
that.
7, yeah.
So 6 and 7 orange. So it's easier for us to. Normally, you know, I never go with 7 French.
You want to cut?
Yeah, you can. You want to cut or just use the, give me the balloon, huh?
How will the balloon will go?
Can we use the balloon? What is this
Yeah,
balloon?
that will go.
2.5?
Yeah, same 2.5
No, no,
balloon which
huh?
you used. Yeah.
No, it will not go. It will not
Why?
go because once you have, the lumen gets compressed.
You have 2
Give me
also.
2.
You want 2? Good. Yeah, here. 2 not used. Yeah, now question is how do you can advance your another over the wire system from the retrograde part of this catheter, or you can just put a balloon now.
You know what you can do?
Yeah.
You're right. Give me the fine cross.
Yeah, you can go back with a fine cross.
Means you want to remove it now? Let's remove it now.
Yeah.
Go with the fine cross and let's remove it.
Yeah.
So two observations again. Our wonderful audience. Is it mandatory to cut that distal tip of the wire, and should you keep the micro catheter during exchange to protect the micro channel?
That's it. So that's where we are putting the micro catheter. Other one, I would say that Antegrade now, you can cut the wire tip and put your 2 or 2.5 balloon to go through it,
Yeah, to dilate it.
to dilate it. Yeah.
But you have to remove this wire, right? Very important. So we can do that now. So what we'll do is, this will have no worries. It's nicely anchored,
Yeah.
right?
Yep.
So I'll keep advancing
So this is the Antegrade we are going.
with the fine cross.
Yeah.
Another lovely compliment to the great job you're doing. We often inflate a balloon in the guide to prevent bleeding, especially in anemic patients, while doing
Okay.
the externalization. Very good idea.
No, but as long as you have Y connector, it will not bleed. We had the Y connector. Yeah. Remember we did through the Y connector, so we will
absolutely.
not. No, but you have some Y connectors which don't have, like co-pilot will bleed, but not this. Okay.
Okay. Very careful.
No, you can take it out now. You
Withdrawal
can take
there
this
now.
out. I'm holding this wire.
No, I
You
know,
can
I
take
know, but see the
the
RC
Corsair out.
Where is it?
I mean, even this has
The
to be
guide will
done.
suck in.
So,
Yeah.
exactly.
You see
It
it's
has to
coming
be.
back, right? So what we need
Yes.
to do is, the other one, I have to go forward.
Yeah.
This
Good.
fine cross.
They're reached there.
No,
There.
no, this fine cross has not reached.
Fluoro? No, I thought it went there.
Yeah, it's
Yeah,
reached,
went
right?
there. Yeah, right there.
Yes. Okay. So now let me take this out. Hold
The
it.
only thing is the right catheter will suck in. It's a normal thing.
Yes, you see that right catheter?
Look at that.
So one of the
I'm taking this out.
continuation here is, do you prefer to
Keep pulling.
disengage
No,
the
no.
catheter or put a wire in the
Right.
aorta
No,
to
no,
prevent?
I would say right,
side.
disengage quite a bit. This can come out.
No.
Why?
This wire has to come out, otherwise it can cut it out in the septal. Okay, hold on. The wire has to come out. Let me go in. You understand? Yeah. What are you doing? If the wire does not come out, where is the wire?
Want to advance the wire a little more? The question was the final step now, that without engaging the guide too much, where we are.
This wire had to come out from this side. You understand? Anyway, now I guess we take it out from the other side.
Hmm? The guide will suck in.
Yes, that's fine.
Yeah. So right guide, you have to disengage a little bit. And you have to hold this wire. Okay, I'm coming, taking it out.
No, you cannot take it out. The wire has to come out first.
Mm-hmm.
Okay, good. Now
Yeah.
the wire is there.
Yeah.
Now hold it and slowly take out the wire. Slow, so it gets
Okay.
sucked in.
So now we are just taking the wire out slowly.
Yes,
We're showing the fluoro.
yes. Now don't
Yeah,
fear,
both of
because everything has to come out when
kiss.
you're coming here.
Mm-hmm. So both are touching each other. Slow. Because whole question is, it can cause the dissection of the septal, dissection of the vessels, all the work which we have done.
Once you reach here, then all this has to come out together.
Yeah.
Samin, I'm reading another question
Action length
exactly
of
as it is
antegrade part.
presented.
Yeah, get us a 300 run through.
300 run through now. Okay, we are coming slowly.
Look at the guide, RCA guide.
Mm-hmm. The biggest thing is the RCA guide. Yeah.
I pulled
okay.
back.
We are coming.
Yeah.
Coming. This wire is coming. Yeah.
Okay, wait.
Good.
Now, right?
Now we can take it out.
Yeah.
Yeah.
Okay, good.
Good. The retrograde wire tech has been out. Antegrade here. Take this one away.
Yeah, out.
Good. Laser, bye. Okay, what is that lady here today or no?
Isha.
Isha is there, or Huda, Amit? Amit is doing the case. Okay, good. As long as somebody is there, yeah.
Okay, some
Magnify.
die. Yeah.
So things are okay? Two rooms? Okay,
Retrograde die then. Let's see. Okay, now I'm in the LED.
good.
Okay,
Fine. That's it.
here we go.
You don't need anything else. Yeah, let's get a balloon. 2.5 balloon will be okay. Not even.
Down
Okay,
the
we'll
home
dilate now.
stretch.
Yeah,
Down
no,
the
you can
home
start your
stretch.
lecture. This is just balloon and.
No, but I want to do a balloon, show the vessel, and then you do the, okay, keep holding, yeah. We are 2.5 balloon already, right? This
Now, what we can do is
Yeah.
we can do a RCA picture. Let's do an RCA guide picture and take the guide out.
Yeah. Good.
Okay, wait. Suck back in the thing.
Good.
What was ACT will? All through? Good?
Good.
Okay.
Sine.
No. Shit. I pulled it out too early.
Not good value or no?
Okay, LV.
Good.
Okay.
Good. No,
Ready?
no value. Yeah. Good.
RCA
Remain
remains
the
nice.
same. Yeah. So this is out.
Yeah.
Now let's complete the.
Very
Yeah, we are
important
2.5 balloon.
to demonstrate that you have not inadvertently hurt or damaged.
yeah.
The feeder.
Yeah. Okay. This is the 2.5 balloon.
Why
Let's
don't we go
dilate,
3
show the
Why
antegrade.
don't you go 3
Go,
and be
okay,
done
get a
with
3
it?
or 20.
Yeah.
3 or 20.
Yeah, dilate and we put one long strand and
Yeah.
done.
Once you dilate, then I go to my questions.
Yes.
Yeah, go to caudal view. Caudal tells you a little better of the proximal LED. Not caudal, yeah.
AP caudal even.
Yeah, no, yeah, just AP caudal. Little RO tilt. Yeah, good. That's it. Go for it.
Look at the left main.
Yeah.
Beautiful.
Yeah. So I think, as we said, the circ, if you feel some concern, then only, otherwise this is straightforward. Now you can see, we'll come back to this question now, is antegrade dilatation. And look at that origin is still very mysterious. It's just overlapping that ramus. Okay, with that note, let's go to our presentation. While a few more minutes, Anu will finish it and then come back. If we can go back to our slides, yeah. So it's appropriate all the way with our, as I mentioned, I stopped there earlier, and we go to the next level. And then basically today, I'm going to give few key messages from some of the interventional trial of 2024, which we are left. We have not covered it.
Go.
Fire trial, STEMI versus non-STEMI outcome, host exam, whether aspirin or clopidogrel, long-term, Excel, impact of major bleeding after CABG or PCI, ischemia trial, 3-vessel outcome, and renovate complex PCI outcomes in diabetes and non-diabetic in the intracoronary imaging. And then lastly, our focus review will be improving the outcome post-PCI, and that is what we do day and night. So that's clearly fire trial. Remember, fire trial was the trial of PCI, the complete revascularization, FFR guided, versus culprit only revascularization in older patient age of 75 and above, done in Italy, and basically showed that complete revascularization was better compared to culprit only, whether it's a STEMI or non-STEMI, and this is where the paper was. Paper basically was whether STEMI or non-STEMI, there was a benefit of complete revascularization. Actually, non-STEMI even was much better. As you can see, death MI was much lower, significantly lower in the non-STEMI compared to STEMI group, and also lower revascularization. So clearly that culprit only versus physiological guided is superior. The complete revascularization was better compared to culprit only. Only thing which we saw a little signal was that higher stroke rate. As you can see here in the complete revascularization group in this patient population. Now this basically is, and so the benefit is both of them, and so. Second, now this is against, there's another trial presented by the European colleagues, senior Rita. Also 75 plus age, non-STEMI patient, invasive versus conservative statement, treatment, and they basically have the result, little disparate results, that there was no difference in the primary outcome of death MI, but revascularization was lower in the invasive strategy, and others are shown there. So I think it's a field is still questionable in my opinion. You have to take it patient by patient. If patient is really good, robust 75, non-STEMI, I would say definitely go for the PCI based on the fire trial. But if the frail patient with a multiple comorbid condition, elderly patient, non-STEMI, medical management is fine. Second, remember host exam trial was the trial of continuation of single antiplatelet therapy after the duration. And the duration basically was in these patients 6 to 18 months of the DAPT, no ischemia, no bleeding, and then they were randomized to monotherapy of the clopidogrel or aspirin. And what they basically found, as you can see here, that patient in the thrombotic composite endpoint with a high bleeding risk patient, they wanted to see the data based on the high bleeding risk or complex PCI. So clearly high bleeding risk, you have a lower event rate with the clopidogrel, and as you can see there, and the second is the patient in any bleeding, any bleeding in this high bleeding risk patient, again lower with clopidogrel. Now thrombotic endpoint in the complex PCI again favored the clopidogrel compared to aspirin, and of course any bleeding by complex PCI was not different. So just to say that overall in a complex case, high bleeding case, clopidogrel had the advantage over aspirin based on this study. Another data is the Excel trial, major bleeding of and mortality after revascularization of the left main, and basically was that if you have bleeding one overall and the bleeding after hospital admission, as you can see, overall bleeding is about significantly lower in the PCI group 8.1 versus CABG is 15.2, but after hospital admission, you can see here that bleeding was still bleeding occurs up to 5 years, with a 4.5% was in the PCI group and 2% in the CABG group.
Okay, give me 3. Oh,
Okay. So just to complete that, you can see
38.
the major bleeding and bark type bleeding in hospital bleeding was more in the CABG group. Post discharge, more bleeding in the PCI group. So they're very clear. So CABG caused more in hospital bleeding, PCI further bleeding after the discharge because of continuation of and likely antiplatelet therapy. And these were the post discharge major individual predictors shown here. But anemia, AFib, female, they all are common determinant of the long term bleeding. Now, but also the very simple, as you can see here, in the PCI group, which is the lower, half occurred in hospital, half post discharge. In the CABG group, majority occurred within the hospital and 12% occurred after the hospital. So key is that CABG has more in hospital bleeding, and the part of their contribution, very little bleeding after the discharge. In the PCI, it's half and half in hospital and post discharge. But whatever it is, whether you have a in hospital or with a CABG or PCI, for both PCI and CABG, all-cause mortality was significantly higher in patient with a major bleed. So major bleed, no matter how it occurs, give rise to a bad outcome on the long term. So that basically was the point. So then the ischemia trial. Remember, ischemia trial basically was the asymptomatic positive stress test and a patient conservative versus the revascularization. Revascularization was decided by the PCI versus CABG. 28% had a CABG, 72 had PCI, and basically showed the revascularization versus conservative strategy in patient with 3-vessel disease. Not 1 or 2 vessel, 3-vessel disease associated with a lower 4-year cardiovascular death and MI and improved quality of life as shown here. So both, whether it's a PCI or CABG, associated with lower event rate, particularly you see the PCI all throughout. CABG had initially higher event rate in the beginning, but later on lower event rate compared to conservative strategy. And these are the individual endpoint, and of course the dyspnea, SAQ, everything else favored basically, as you can see here, the intervention versus the conservative approach in these patients. So this basically is that patient with a 3-vessel CAD, revascularization, either PCI or CABG associated with a lower MACE rate and quality of life. The last one is the Renovate complex PCI. So say that, is there a difference in benefit? This was the trial of intracoronary imaging, 75% IVUS, 25% OCT to see. And the complex PCI, the benefit of the intracoronary imaging was there. So now they said, let's look into diabetic versus non-diabetic patient. And very interesting, diabetic patient, look at that. There was no difference in outcome in the diabetic patient. TVF was identical in the diabetic and versus non-diabetic. In the diabetic patient, imaging guided versus angiographic guided, as you can see here, except definite stent thrombosis was lower in the imaging guided, but others were not different. Now, once you go to the non-diabetic patient, story is totally different. There was a significant benefit of imaging. So what we learned basically from the trial is that in the secondary analysis of the subgroup of patients in the Renovate complex PCI, intracoronary imaging reduced the risk of TVF compared with angiographic guidance in patient without diabetes, but not in patient with diabetes during PCI. So what does that mean? That in diabetic patient, we need to do more in terms of stent optimization, more glycemic control, and other secondary factors will be needed to improve their outcome, not necessarily just the imaging point of view. So that's a lot of interesting focus points which I mentioned. Then another one is that how do we improve the outcome of PCI? As you see, the PCI numbers which were down at one point are going up. Actually, globally, there are much more PCIs are done, almost 8 to 10 to 1 ratio. In India also, they will do about 800,000 PCIs this year, or means the academic year they did, and America did close to 1 million. So, and the CABG number continues to go down, and partly because of the success of the PCI in a short and long-term outcome, and therefore they basically showed that the long-term management of post-PCI patient have 3 main principles. Yes, we can do a great results acutely. We know that imaging improves, good stent and so lifestyle modification and reduction of risk factor. Second, implementation of secondary prevention therapies, risk factor modification, and thirdly, timely detection of restenosis. And all those things are basically, this article really emphasizes on every aspect of the promotion of smoking cessation, regular physical activity, healthy diet, blood pressure, diabetes, lipid and weight management, prescription of secondary prevention therapies, balancing ischemic and bleeding risk, and avoidance of routine surveillance for restenosis. Yeah, this is our paper basically show that where the 40% TLR rate now is about 3% with the current generation stent, but it still happened. And this is where it shows that even after 1 year, you have the event rate, whether it's a bare metal or DES, MACE and TLR occurs at 1 to 2% per year with no plateau. So you continue follow these patients 20 years, 1 to 2% will continue. Yes, the second generation DES have a lower event rate, but they continues rest of the life. So why? Many of them are not the target vessel. It's the new lesion which create the problem with these patients. So therefore, the whole issue was that PCI is the mainstay procedure of treatment of CAD. So therefore, since the advent, we have changed quite of medical management, our restenosis rate, non-invasive evaluation, all those put into together to make the better practice. And what is adherence now has been, and lot of emphasis, both ACC and European Society guidelines says that the cardiovascular risk reduction by the healthy diet, exercise, achieving normal weight, leave smoking, take control of cholesterol and blood pressure, handle alcohol consumption, and yield to stress management. So all these things are important, and along with rehabilitation. So this is actually very nicely written as a multidisciplinary behavior intervention in these patients. So lifestyle modification on the left side, medical management for secondary prevention in the middle, and the restenosis that you need to pick the patient before they get into trouble by the careful monitoring of these patients. So what has been shown? That you need to have mobile health intervention, behavioral, simplifying modification, regime, multi-professional and family involvement. So everything when we do, it's not the patient only, you have to involve the family. That's the class 1 indication. And adherence require the patient healthcare provider, the patient, the therapy and healthcare system. And now we can encourage the patients on the mobile friendly, that your sugar is off, your LDL is out, you're taking your medications, and all those shared decision making really has improved the overall compliance. Now, there are few data. What about the prevention in terms of the diet? Mediterranean diet versus low-fat diet. Cardio Prevents is a randomized trial of the Mediterranean, which has a lot of fruits compared to just the cut down on the fruits and vegetables compared to low-fat diet, and basically showed in about 1,000 patient study that the Mediterranean diet is associated with a lower event rate. Many of these patients have the secondary prevention after getting their stent and so. So secondary prevention, the Mediterranean diet was superior to the low-fat diet in preventing major cardiovascular event. Therefore, clinical practice of use of Mediterranean diet, low-fat diet is not enough. Whole question about the hormonal therapy is very complex because of where to do in high risk cases. It is appropriate that you can that not using the hormonal therapy, maybe the low risk hormonal therapy with the recent menopause, normal weight, normal blood pressure. So this field is very complex, but yes, we need to have a accurate guidance that which patient should get a hormone therapy after intervention as a secondary prevention. Then as I mentioned, the cardiac rehabilitation. So very important, multiple trials have shown for the cardiac rehabilitation actually improve outcome. And you see, particularly earlier trials, exercise-based cardiac rehabilitation with the meta-analysis and particularly post-MI shown lower mortality and lower re-MI, and of course, patient feeling better. So rehabilitation is an important part. As you also know, it is the indicator for our the Q-HIP for the ACDR, NCDR, they give you the data that how much patients you have sent for cardiac rehabilitation post-stenting. And the number is about 72%. You have to be about 72% because that is approved by insurance. Only problem is it's kind of a waste of time in my opinion, because the 1 hour, 3 times for 12 sessions. So it takes 12 weeks, total 36 sessions, but it takes so much time. And more importantly, the reimbursement is so low. Most of the places, we used to lose almost $500,000 for the cardiac rehab program, but that is essential for the institution and for the teaching program. So then question comes, what are additional to improve their outcome? One of them, using the PCSK9 inhibitor evolocumab in the 4-year trial, shown that patient with a multi-vessel disease, you're done whatever you need to do from your PCI, antiplatelet therapy, everything, but adding, irrespective of the LDL, adding the PCSK9 improve the outcome, particularly patient with a multi-vessel disease, as shown here. It's all of them, but more so in the open label extension was superior. So evolocumab reduced the rate of major adverse cardiovascular event in patient with or without multi-vessel disease. Benefit trended to occur earlier and was larger in patient with multi-vessel disease. However, the magnitude grew over time in both groups. So clearly, they make a point of making it a class 1 indication with the patients. Now, second, many drugs in the type 2 diabetes, GLP, STLJ inhibitors, all have shown to reduce the cardiovascular event and subsequently mortality and TLR, the GLP, many trials have shown overall, basically, that structural homology reduce risk of individual MACE with a GLP receptor with a lower mortality. Then question was the diabetic control. We actually published the data from our own center that A1C, that which group of patients have a lower event rate after diabetes. You can see the sweet spot was between 6 to 7.5. So less than that, you have more death. Higher than that, you have higher MI and target vessel revascularization. So basically, your hemoglobin A1C should be between 6 and 7. And clearly that now patient comes back. So how do you follow these patients? Patients have done, you are given good medical therapy, but these patients have to be followed regularly. By doing electrocardiogram, follow-up echocardiogram, and not a routine stress test. And this is where they put it, that patient follow-up of the established patient, that clearly that you follow anytime you start developing the LV dysfunction, then you go forward. If you are asymptomatic, no need for doing a stress test, as has been shown by the studies and so. So clearly the annual visit, every few months visit, and there was a randomized trial of routine. Even in a high risk cases, the routine, the functional testing up to 2-year follow-up compared to standard care that you did not send for the stress test, and you found that outcome from any point, the primary composite outcome, MI, unstable angina, all were identical in 2 studies. The only thing was that a patient in the routine functional testing had a higher angiography and repeat revascularization. So, and even in the diabetic, that did not change. So basically, that routine stress test post PCI asymptomatic patient is no longer indicated now based on the trial. Then there are 2 trials of the colchicine. Although the third one I'm going to show next month webcast, the Colcoat and Lodoco 2, both have shown colchicine better. But now this all have been refuted by the new trial, Clear Synergy, which showed no benefit. But people still give colchicine. Anti-anginal drugs, they have clearly that whatever require patient symptoms and ejection fraction point of view should be individualized. And of course, ACE inhibitor should be given to these patients. The DES, if you come back, then you use a drug-coated balloon. Lima, if you're restenosis, redo CABG, and patients, when you do PCI, do the PCI of the native vessel. Antiplatelet therapy has become very clear. Patient with a stable CAD 6 months, unstable CAD 12 months of DAPT, but some cases you can stop after 3 months, even shorter, particularly bleeding risk. And third, you can take away the aspirin 1 to 3 months after the PCI. And once you are giving the NOAC, oral anticoagulation patient needs for lifelong, you can give a single antiplatelet therapy, has been shown by various programs. So with that note, I take you to the take-home message, and then we'll ask Anu to show the beautiful work. The one is complete versus culprit PCI in STEMI and non-STEMI, 75 years, clearly 2 thumbs plus. Clopidogrel versus aspirin along long-term post-PCI, 2 thumbs up. Lower bleeding post-PCI versus post-CABG and mortality, clearly the 1 thumb up. And then revascularization versus conservative strategy outcome in 3-vessel CAD, you should be doing more PCI. in these cases rather than conservative, and benefit of intracoronary imaging in the complex PCI non-diabetic patient, not in diabetic, 2 thumbs up. So in the recent time, PCI outcomes have improved significantly, largely improved stent design, increased imaging, and shortening depth duration. So lifestyle modification, aggressive secondary risk prevention, and medication to treat and have a balance of ischemia and bleeding to managing these patients has really helped to improve the outcome of these patients both in acute and chronic disease. So 3 questions. Following statement is false regarding the results of the FIRE trial, comparing complete versus culprit. Complete trial was beneficial in both STEMI and non-STEMI. Outcome of the complete versus culprit PCI was more pronounced in non-STEMI versus STEMI. CVA outcomes were lower in non-STEMI patients after complete versus culprit. Bleeding outcomes were similar between 2 strategy. Stent thrombosis rate was similar between 2 strategy. Clearly was CVA paradoxically was higher in the culprit, in the complete revascularization of the non-STEMI group compared to the culprit vessel PCI. Now, following statement is false regarding host exam, comparing aspirin versus clopidogrel. Clopidogrel was associated with a lower major bleeding in high bleeding risk patient. High bleeding risk patients have higher major bleeding versus non-high bleeding risk patient. The clopidogrel was associated with the lower thrombotic events in complex PCI patient. Clopidogrel was associated with a similar major bleeding in non-HBR patient, and clopidogrel was associated with significantly lower major bleeding in complex PCI. Answer is E. Complex clopidogrel was associated with significantly lower major bleeding in complex PCI. Answer is no. It was only in the high bleeding risk case. The third question, following statement is false regarding the interaction of major bleeding after PCI versus CABG in the excellent trial at 5-year follow-up. CABG had lower post-discharge major bleeding. PCI had lower in-hospital major bleeding versus CABG. About 2/3 major bleeding occurs in hospital, while 1/3 after discharge. And major bleeding was associated with higher mortality only after PCI and not CABG. And after PCI, half of the major bleeding occurs in hospital, while other half after discharge. And clearly the wrong is, in this case, D, major bleeding was associated with higher mortality, whether it's a PCI or CABG. With that note, I stop here and I'll ask for our audience now the claim the CME credit. They can go on to the webinar, log on, and this will remain active for 24 hours to go back and get the CME credit. We encourage people because I'm doing it for another 4 or 5 months, and then we decide whether we need to continue it on the long term, our CME credit. And Anu, you want to show that now?
Such a splendid review to top of an exceptional case. Anu, show us what you got finally. I have probably 30 people online waiting to see the results.
Yeah.
Okay, so we can see the angiogram. Okay, yes, right. Where did we leave, right? Oh, hold on.
I think we were at number 44 or something.
Yeah, you saw us going all the way down, right? So we just did why IVUS was open. We wanted to show that, of course, that ostium of the LAD will be okay, and that's how we re-entered. Okay, so that was IVUS, which showed, lumen to lumen, which we knew that we were a little bit subintimal. So you can see here that we are a little bit subintimal, and then we again, through the ostial LAD, we entered into the left main. That we knew that we were subintimal.
But you want to show the IVUS now? IVUS
we can show the IVUS, we can show that.
Tell them the IVUS before you go to the main result.
Yeah. So the distal edge,
Not much calcification.
Nope.
Lumen. So now come pullback start. Then the IVUS is in the edge, and we see the true lumen here. So now this is IVUS is in the subintima. So now come more proximally to subintima. This is also subintima. Now this is the trifurcation. We see the circ and the lesion still subintima.
No, I would not say subintima there. You have entered the left main. Yes. Yes. That's okay. Yes. But when you reach the left main, you are through the
No, but let me ask you, is it the 3 branches or LEDs coming from the ramus, whatever we saw?
Trifurcation.
It's a trifurcation. Okay. Yeah.
It's a trifurcation.
Trifurcation. So,
okay.
Yep. But proximal LAD to mid LAD is subintima.
Big vessel. Very big vessel.
But the start of the pullback is true lumen. So true, sub true. So,
okay. Yes. All right. Go to the angiogram again, please.
So then this is where we took a 3038, because distal was just about there. That is the one. And then we post-dilated with 3.5. And Kiski still was not happy. Proximally, he says we can show the IVUS run that it is not fully opposed, right?
Sure. Beautiful.
Yeah,
That's a good one.
malopposed, and then he still keeps saying that's a little
So this is
hematoma in the left vein, which you
yeah,
don't see on the angiogram.
Yeah, but there's a malposition in the proximal left main part.
Yeah.
So we did a pot.
No, that's ostial LAD. Maybe one strut is in the left main.
So and this is a final.
Yeah.
Like less malposition.
Yes.
And the LA is like a good expansion. MSA is like 6.1. So yeah.
Show us that hematoma which you're talking about.
Yeah. So it's a proximal left main, still some hematoma here because in the procedure we did some subintimal, but the lumen is open.
But very big lumen.
Yes, true.
Okay. Show the angio now.
Okay, let's go to the angio.
And a CTO is all covered.
Good.
Aye. So this is the cranial
Other
picture,
views.
making sure that all those septals that we went through, we traversed through is intact. We didn't cause any hematoma or there's no perforation at that level. And this is the caudal.
Wow. Look at that.
Anu, one of the best cases in our repository. Outstanding job, great case selection, superb skills, tremendous teaching, and I must thank our audience for their robust participation today. Samin, Anu, any final comments?
No, I just want to make it clear that I know there were a lot of suggestions about various techniques, how to handle it. And I think we showed it, how to do it the Sinai way.
Now, I would say that just to be clear, all the suggestions are appropriate at every step. Changing the wire, this and that. What I still don't agree, putting a wire, prophylactic wire in the circumflex. I think that's not needed at all.
Yeah, that's not needed because you don't know how long it's going to go. There's a risk of always thrombus formation. You see that we just did 2 wires and always we were careful looking. So you essentially have to be paying as that was a good pickup that patient is becoming a little uncooperative. Is it some angina he was having? It could be also he's been lying long. So the total time is 52 minutes, contrast is 220 and air karma 4.4. We are less than 5. We haven't reached the limit of 5 with the radiation. So that was it. And I think going back to one other suggestion, people kept saying, yes, we like the suggestion, pull back, re-enter with a different wire from the septal when you're entering into the proximal LAD. The other one was, they mentioned about the knuckle. It's same, where people do multiple dissection and re-entry and all this thing. Knuckle is something you have seen us for so many years, so many CTOs we have done. I'm not a believer of that because you just cause more dissection, hematoma, and I think the perfection I always tell you is that you got to enter at the proximal cap and exit at the distal cap. Here, enter at the distal cap and exit at the proximal cap. That is the finesse of CTO, and that is what people should try to learn, and that is how they should try to do it. Dissection re-entry is not a nice finesse and not a nice way to do a CTO.
And that's a star or mini star technique. The Stingray device has completely disappeared. I haven't seen anybody using it. Maybe some people using for some interest, but there's no need. We never, because those were data showed that more antegrade or retrograde dissection re-entry, they were associated with higher total occlusion, periprocedural MI, total restenosis, as well as patient coming back with a CTO again.
Anu, Samin, excellent closing comments. I thank the audience again. We'll see you on February 18.